Cool. Mm. Okay, so maybe while we're waiting for some more people to log on, maybe we can just quickly start. The first part of this was just a recap of maybe the most critical parts of what we've been trying to convey for this month, which was cardiac output. A lot of equations, and I think when you first hear about cardiac output, you need to hear it quite a few times to be able to internalize it. It's not a one-hit wonder. And of course, cardiac output is the basis for almost everything that we do, never mind in ICU, but in medicine, in health, in a person's health, in a person's state. No matter what their condition or what the procedure was, there are certain elements, if not all, that you need to take into account regards cardiac output to be able to manage the patient. So this actually is for everybody. Of course, you can get more advanced once you add cardiac output monitoring, and I'm going to be discussing a little bit of a case in a little while after we've gone through the basics again. And just to show you how valuable this kind of thinking is and what a huge difference it made to the specific patient. But once you start working with cardiac output monitoring, you'll see what a big difference it makes to all your patients. Having those extra values and having a more complete picture of the patient really helps to make better clinical decisions. Okay, so let's carry on here. Okay, so cardiac output, the first mother of all equations for this is cardiac output equals heart rate times stroke volume, which I hope everybody knows now and will be able to wake up in their sleep and tell me about it. Okay, so it's the amount of blood pumped by the heart in 1 minute. That is the definition really of cardiac output. And if we look at that word, that SV there, stroke volume, that's the amount of blood ejected by the ventricles in 1 beat of the heart. And that is going to be measured in milliliters. Okay. And heart rates, that's going to give us the time part, is amount of beats in the heart in 1 minute. We know we measure heart rate beats per minute. So if we times these two together, we will get the amount of blood pumped by the heart in 1 minute, which I think is cool, makes sense. Okay, so if we have a look here at putting that into practice, a normal heart rate, a lot of people have been saying a normal heart rate is 60 to 100. That is what we allow for sinus rhythm. But a normal heart rate is actually a bit tighter than that. And I would say around 60 to 80 beats per minute. Once we're going above 80, we already should start thinking, why are we compensating? Why is our body compensating? Because that's the first thing that happens. As soon as this drops, there's a whole lot of mechanisms in our body where we have our chemoreceptors and all our homeostatic, sorry, that was my dog's butt. All our hemostasis takes place, and the first thing that will happen is our body will give us a sympathetic nervous response, and we will up our heart rate a bit to maintain an adequate cardiac output. Remember, cardiac output's all about delivering oxygen to our tissues and our organs. So as soon as there's a problem, our body will try and make some changes to increase our cardiac output to maintain adequate oxygenation so that we don't get hypoxic or high lactates, for example. Okay, but let's just see, in the normal situation, we say our heart rate's about 70 beats per minute. And a normal stroke volume is around 70 mils per beat, which is nice just for the normal example in your head. They're both the same number. So if we times the 70 by the 70, we get 4,900 mils per minute, which is quite a mouthful. So we just convert those mils into liters and we get 4.9 liters per minute. And we can make it even simpler to remember, and we can just round it off and say about 5 liters per minute. And that's important to know for all sorts of things. And something that's coming to mind right now in a practical application is when we're on ECMO, on VA ECMO, that flow that we generate from the speed that we set is also in liters per minute. And if we're on full ECMO, we usually say it around 4 liters per minute. And that's equivalent to almost the normal cardiac output. So that means the ECMO machine is responsible for your cardiac output if you're around 4, and you're pretty much dependent. Anyway, let's not take it too far. Let's just remember the 4 liters per minute for now. And let's see what's next. Okay, so what's next is that we're all different, and that we can't just blanket statement this to everybody and say all of us need to be 5 liters per minute. We're all different shapes and sizes, and we have a different amount of cells to provide oxygen with. So if we're very tall, like this beautiful young girl, or if we larger, obese people, or even just big people, they have more cells. And if you're more petite, you obviously have less, and you don't need that much. So how do we determine how much each individual needs? Because we want to get more specific if we're looking after a critically ill patient. And how we do this is we take into account body surface area, and we don't have to work this out ourselves. The cardiac output monitor works it out for you, but you have to put a very accurate height and weight into the initial setup. Once you have that, it divides a lot of these factors by the body surface area, and it changes them into, instead of cardiac output, we now have cardiac index. And as soon as you see that word index or an I at the end of any value, you know that it has been divided by the body surface area of your patient. And now you've got a very specific value for your patient. So whilst you'll get all the values, the ones with the I at the end are probably more valuable in the sense that it is specific to your patient now. Okay. And of course, it's going to be divided by something like 1 point something. So it's going to be less than the 5. It's usually cardiac index is around in the greater than 3. But I always say when we teach cardiac output, you never have to remember the normal values out of your head. There's quite a lot of values that come out of the machine, but it does come with a card. There are resources with all the normal values on. You don't need to remember them out of your head. So don't panic about that. You just need to know what they mean. Okay, so let's move on here. Okay, so the next part, all right, is splitting up what makes that stroke volume. So we've still got cardiac output equals heart rate times stroke volume, the mother equation. But now we need to know more about the stroke volume. What factors influence the stroke volume? And remember, the stroke volume is the amount of blood that's pumped out of the heart. Okay, so obviously, if we're talking about volume, we need to know how much volume was there to start off with in the ventricle. And that is our preload. How much volume is there for the ventricle to squeeze out? So how much volume came in? Remember, once the ventricle squeezes volume out, it doesn't squeeze the entire preload out. Otherwise, you're going to have a vacuum once the ventricle relaxes. Okay, so there'll always be a little bit of volume left over. That little bit of volume left over is called the end systolic volume. But what I'm getting at is they're not the same amounts. Preload is normally around 120 mils, which is quite a lot. If you think about, if you're in ICU and you think about our 50 mil syringes, it's 2 of them plus another almost half a one. That comes into the ventricle, and then the ventricles contract. and then a preload goes out. A stroke volume goes out of the ventricle, and then an end systolic volume is left over. So the amount that's available to the ventricle will obviously affect how much it's able to eject out. So preload is very, very, very important. Okay, and we will get, I'll show you where we look for it on the cardiac output monitor as well. Okay, what else can influence the amount of volume that the heart squeezes out? Of course, how powerful is the ventricular squeeze? Our hearts can adapt to different situations. If they're under a lot of stress, exercise, anxiety, all sorts of things change. And we might say we power lifting something or extreme physical exertion, we will have a more powerful squeeze in that ventricle. We'll have our beta-1 receptors being activated by adrenaline, noradrenaline, all sorts of things, and we'll have a greater contractility, and then we'll have a bigger stroke volume, obviously, if the heart is squeezing harder. If we're at rest or sleeping, we don't need that. We can have the most minimal contractility, just an average normal contractility, because there's not that much demand. As soon as there's oxygen demand, we're going to have more, our bodies will try to, whip our hearts into a bigger contractility by having adrenaline and NOAD secreted here. Okay. And of course, in the ICU setting, we might influence this even more with inotropes. All right. The last factor that influences stroke volume is afterload. And this one is quite special because if we increase our preload, we should get more stroke volume. If we increase our contractility, we should get more stroke volume. But afterload, if we increase it, we get less stroke volume. So we say it is inversely proportional. And what is afterload? It's how much resistance must the ventricle overcome when it squeezes. So we have this heart that's squeezing, but if we've got a very thin, not thin, what's a better word? Very vasoconstricted aorta and vasculature after that, it's going to be very difficult for the heart to squeeze this blood out. And I said in my in-service training, think of a double thick milkshake, right? So you order this amazing thing, it arrives at the table, and your waiter gives you a normal straw, and you put the straw in and you like sucking on this thing, and just nothing comes out, and it's like the most frustrating thing. And then the waiter comes and brings you one of those big straws, and then you're all happy because you can actually get to this double thick milkshake because now the volume moves. So it's a similar kind of principle, although not quite scientific. But if you've got a very constricted aorta, it's going to be difficult for the ventricle to eject against that. If you have a aortic valve stenosis, remember that's the valve that's between the left ventricle and the aorta. If it's stenosed, the hole is much smaller, exactly like the regular straw. And because it's got a smaller hole to squeeze through, the afterload is very high in aortic valve stenosis. But what I wanted to mention was if you're giving the patient high doses of pressors, which we know increase our afterload, causes vasoconstriction, think of something like phenylephrine or NOAD at a very high dose, vasopressin, of course, the most powerful. We must be very careful that we're not over-constricting, because then we're actually making more work for the heart by increasing our afterload. And with the high afterload, you might have a falsely great blood pressure on its own on the monitor, but then because you're so vasoconstricted, you're not actually delivering oxygen to the tissues, what cardiac output actually is, and you start getting the little black fingers. And can you imagine if that's what your fingers look like, what's happening at the end of your kidney or your brain or any of your periphery, right? So this is why afterload being high is the silent killer. High blood pressure is a silent killer. Everything looks okay, but in the meantime, you're not getting proper perfusion to your organs. Okay, so it sounds a little bit scary, I suppose, having this mystery afterload that we don't actually know when we're looking after a patient. But how do we monitor this, for example, as an ICU sister? So I think if you've got a patient that's got a normal lactate, that should give you a lot of a peace that your patient is receiving enough, is the cardiac output is probably adequate. Okay, so lactate high lactate can either be from hypoxia or from a lack of cardiac output. So if your patient's blood gas, if the PaO2 is fine, your SATs is fine, your lactate is within a normal limit, that should give you a lot of confidence that everything's okay with your patient. Of course, you can go one step, more rudimentary than that. Even before a blood gas, you can examine your patient, look for the capillary refill and the peripheral pulses if they're fine. There's no signs of any shock, like pale, clammy kind of situation on your patient. If they neurologically sound, we know that there's enough cardiac output to the brain. So there's a lot of things we can look at, but if they start becoming shut down at all in their periphery, say you started some big gun inotropes and pressors or something, there should be a reason for that, of course. But if you notice a decline in their perfusion to their hands maybe, or the lactate starts rising, and the blood pressure might still be low, and now you're not sure. Must you go up with pressors? Must you give fluid? What is the problem? Is it preload contractility or afterload? It will be worth it to put on a cardiac output monitor, because the monitor will sort that question out for you very quickly, and you'll be able to make a better decision. Remember that one of the worst things you can do in a patient that's critically ill is give them fluid that they don't need. It goes into their lungs, they might get pulmonary edema, and you might then, instead of dodging a ventilator, actually put them on a ventilator because of a wrong decision. So I would really recommend, if you see some of those signs, to try and grab the cardiac output monitor. If you need, in cardiac output monitoring, there's two different ways. We can have pulse contour analysis. So we can just add the cardiac output monitor into our existing A-line setup, and you can get some answers. But even better is, of course, the PICO, right? Where you can get more values and you can see more about lungs, especially. But that requires a special A-line to be inserted. So I think in a jam, maybe just put it on and just check the pulse contour analysis. You'll be able to get SVV, SVI, SVRI, so you can see your afterload. You'll be able to check out your preload. But if you feel like the patient is really struggling and there might be a respiratory thing and a cardiac thing, I think try and get someone to come and help you and put in a PICO catheter, and then you can do the thermodilution as well, so that you can get even more values. Yeah, I think that's all that I can think of there. I think it's just important to note, like, if you're nursing a patient and your patient's blood pressure drops, it's one of these three things, or should I say four things. It could, if your heart rate is normal and it hasn't decreased, it's one of these three. It's either the preload, the contractility, or the afterload that's your problem. And you need to troubleshoot it, even without a cardiac output monitor. You need to think to yourself, what is the issue here? Is my patient dry? Could it be that the patient needs volume? Is there a problem with my patient's EF or contractility? Is there a problem with the afterload? Also, if they get septic, they vasodilate. And that also, even though the afterload is low in that case, because they've dilated, you'll also have a problem with your cardiac output, because if they're so dilated and the ventricle squeezes, it results in a very low blood pressure. Afterload, many of these factors need to sit in a sweet spot. So we don't want a too low afterload. We don't want a too high afterload. So we need to troubleshoot it. And if you're having trouble and it's not obvious, put on the cardiac output monitor is my message to you. Okay, so let's quickly check this out. Factors influencing preload. Okay, we've got venous return. So of course, remember we're talking about now the blood that returns to the ventricle. Okay, so on our right side, we can think of our IVC, SVC, and coronary sinus that are emptying deoxygenated blood into our right atrium and then goes to our right ventricle. What will influence the amount of blood coming in there? It's venous return. And there's this horrible term that sounds so gross to me, muscular milking, right? So when our deoxygenated blood returns to our heart, it comes up through our limbs and, through our muscles actually play a role in ensuring that tone. And as we move and so on, our muscles actually assist our veins to bring up the blood back to the heart. We've also got a respiratory pump. So as we breathe, obviously our thoracic pressure increases and decreases, and that also helps to bring the blood back. Okay, we've got venomotor tone and venoconstriction. So obviously the health of our veins are a problem as well. We use our TED stockings for our patients here to bring up that blood to make sure that they don't get edema lower down and that we have better venoconstriction. Because of course they have a bit of inflammation in their legs when they have a CABG, for example. Also, I just put here, remember, if you've put your patients, say, on non-invasive ventilation, on CPAP, we have a continuous pressure going on in our thoracic space, and that can actually reduce your preload. So if you've got a patient that's dry, that already has an issue with their preload, and you put them on CPAP, they might decline further because now the preload is completely, is even less than it was if you miss that before you put a patient on CPAP, and they might get very unstable. So just a little reminder that if you've been instructed or you've decided to put your patient on CPAP, I'm talking about non-invasive, just make an assessment quickly of their hydration status and check out about the preload, where they are before you put it on. Okay, and then a very interesting one is filling time, and I did make a TikTok about this if you want to check it out again. If your patient becomes tachycardic, or say also any fast rates, even the AF, so say the heart rate goes up, we will obviously have less time for the preload to come into the ventricle before the next beat. And because it's happening so fast, I said in the TikTok, it's like a baker trying to fill up muffin cases in a faster speed. You might not be able to get as much into each case because the speed is too fast, and say the trays are just moving. It's a kind of similar idea where the preload decreases just because there's not enough time for it to get into the ventricle because the heart rate is too fast. So it might be applicable in a certain patient to give them a beta blocker to reduce the filling time. To increase the filling time, to reduce the heart rate and increase the filling time, and thereby getting a better preload. So while we said in the original equation, cardiac output is heart rate times stroke volume, sometimes if that heart rate is too high, the stroke volume will drop, and then you won't get a better cardiac output. So that's something to consider too. If you're struggling with cardiac output, have a look at your heart rate, and if it's too fast, think about filling time. Okay. Another factor is Frank-Starling's law, and that is all about the elastic band, about the stretch. So remember, this story is about how preload affects contractility. And if you pull on an elastic band, and you pull it even more, you stretch it even more, you'd expect to get more power as it shoots. And that's kind of what they were saying. These two cardiac physicians were saying, we need the ventricle to stretch a bit so that we get more cross bridges in the myocytes, which are the specialized cells in the myocardium. And with a bigger stretch, there's going to be a bigger contraction. So increasing the preload might even increase your contractility is what they're saying. But while that's definitely true, the problem is in heart failure or, MIs and so on. If you have a dysfunctional ventricle, especially in heart failure, you'll have remodeling and the cells actually become fibrous and they cannot stretch more. And then what happens in that case, if your ventricle cannot stretch, the extra fluid might end up in your lungs. So you go into pulmonary edema because it's now backlog because you've increased the preload in the hope that you'll get more stretch and more contractility, but it might not be possible always in every patient. So a big warning sign for that one, if you've got a patient with a low ejection fraction or heart failure or an anterior MI, I would say, if you see those sort of history of that or even current, be very wary of giving extra preload. Okay, so let's quickly talk about the ejection fraction. I think this is the last part here, and then we're going to talk about a cool case that we had. I'm sure in the ICU we've heard this term many times, ejection fraction, EF, and it's always in a percent. Hey, so where does this equation come from? It's actually simpler than one thinks, perhaps. So it's all about that volume that the ventricle ejects. And remember, in the beginning of in the cardiac cycle, we have this passive filling of the ventricle. 80% of the volume comes into the ventricle all by itself without any contraction anywhere. And as the atriums fill up with blood, eventually the pressure in the atriums is enough to open up the valves on their own, and the atrioventricular valves open, and 80% of the volume that the ventricles get is from that part, that passive filling. Then we have atrial kick occurring. So we have electricity through our atriums. We have a P wave generated, our SA node fires, and our atriums contract, and the last 20% of the volume goes through to the ventricle. And that is atrial kick. So it's very important to know that, because if you lose the atrial kick, if your patient goes into AF, the atrium's just shaking, they're not doing the nice contraction, you're going to lose 20%, okay, of your preload. And remember, another word for preload is this EDV that's on the screen, end diastolic volume. So at the end of diastole, how much volume is in the ventricle, loaded into the ventricle, ready for the ventricles to eject? It's the EDV or preload. And I said that's around 120 moles. Okay, then the ventricles contract. The electricity flows through our AV node, bundle of His, through the bundle branches, Purkinje fibers, and we have ventricular contraction, and the ventricles contract and they squeeze. And the amount of blood that they squeeze out into the aorta and pulmonary trunk is the stroke volume. The amount of blood that's left over after the contraction is the end systolic volume. So if we want to work out how much stroke volume, all we have to do is the amount of blood, the EDV minus the ESV. So at the end of diastole, say the ventricles were loaded with 120 mils of blood, and that after the contraction there's 50 mils left in the ventricle, we know that 70 mils went somewhere, and that is the stroke volume that's gone out. Okay, but to get an EF, we want to know what percentage of the available blood, the EDV, was squeezed out, and that's going to be our stroke volume over the EDV. And in this example, it's 70 mils over 120 mils, and that'll give us a EF of 58%. And to a newbie, that might sound low, but it's actually completely normal. Have a look here at the American Heart Association classification of ejection fraction, and you'll see that a normal ejection fraction is 50 to 70. Remember, you shouldn't get higher than that because we don't want the ventricle to squeeze it all out. Otherwise, we have the vacuum, like I said, it's impossible. Okay, so we'll never have 100%. 50 to 70 is perfect. 41 to 49 is a reduced EF, and then a markedly reduced EF is lower than 40. Okay, and that's when we start thinking about heart failure or a very bad MI, for example. I hope this makes sense. Are there any questions about any of this while we're at it? Is there anything we want to explain again? Okay. Okay, so let's move on then. Okay, so now we add a cardiac output monitor because we want more information. And I thought this was quite a nice slide. These include the pico measurements, just to show you the different factors that we've now learned about in cardiac output and which variables or which numbers on the cardiac output monitor do they correlate to. So this might be a good one to screenshot, or I'll also, I think it's on our website as well in the blog post under the cardiac output workshop. So you can have a look there for it. Obviously, we're going to, if we talk about cardiac output, we're looking at the CO value and even better, the cardiac index, right? Stroke volume, we've got SV. Chronotropy is that fancy word for how fast the heart is beating. So we're looking at the heart rate. Blood pressure, typically we look at SBP, DBP, systolic blood pressure, diastolic blood pressure, and of course our MAP, mean arterial. If we're looking at preload on a pico, we're going to look at this thing called the JEDI, the global end diastolic index. Okay. And then fluid responsiveness, we'll look at SVV and I think it's actually PPV, pulse pressure variation and stroke volume variation. And I just wanted to share maybe with you guys as well. They said to us in that cardiac output workshop that we could get the PPV on the monitor without a cardiac output monitor on, because we've of course got an arterial trace. As long as you've got an arterial line trace, you can get PPV. And no one had ever, I didn't know about that at all. So I checked it out and it is true. You can. I got it on, I can't remember if it was Drago or Philips, but I'm sure it's available on both. You just go into the actual module and you'll find you can just switch it on, the PPV, and it's very useful. It's just so that when we have that arterial line swing, that we know, that we can see if someone walks past you and you know your shift leader and says, oh, your patient's got a swing on the arterial line. It just means that it's doing this shape, right? And it could be indicating that the patient is dry. And to get it in a more quantitative form, instead of just saying, oh, there's a big swing, you check out the PPV, you can switch that on and have a look. And if it's greater than 10, or let's rather say greater than 13, it could mean that your patient is dry. So have a look at that one. You can switch that on while you're waiting for the cardiac output monitor to arrive, or maybe we can switch it on all the time. I don't know. Okay, let's have a look some more. Afterload, of course, we're looking at SVRI. So it's systemic vascular resistance index. The one without index is obviously just SVR, systemic vascular resistance. And that's another word you can use interchangeably for afterload. That one's going to be very pertinent if your patient's on pressors, or if the patient is septic and you think the patient's very vasodilated, that value will guide you to increase the pressors, or if it's too high, to decrease the pressors. Okay. Think of the double thick milkshake. All right. Contractility. Without the pico, we'll probably look at cardiac index, but here's some more values that we can use on the pico for contractility. And then my favorite part of the pico is probably this last bit that includes pulmonary edema. So apparently pico monitoring can pick up pulmonary edema way before an X-ray ever can. And it actually can estimate for you your extravascular lung water index. And then, of course, this PVPI value, which they taught us, will actually tell you whether the pulmonary edema is being caused by respiratory failure or cardiac failure, which is really great, so that it can point you in the right direction of what might be going on with your patient. And this was very, very interesting in the case that I'm going to show you guys now. Okay. This is the little resource that we should use with our cardiac output monitor. And you'll see it's been very nicely designed here. We've got the 4 factors that influence cardiac output: chronotropy, preload, afterload, contractility. And it's going to tell you which values to look at. And then, of course, the normal values are included there. So here's our extravascular lung water index and PVPI, which is the pulmonary vascular permeability index. And I think this liver part we don't have available in South Africa, but those PICO monitors can do even more. Cardiac index, they've given us normals of 3 to 5. And what else? Yeah. You can see here they've given us a normal PPV of 0 to 13 and an SVV 0 to 10. Those are the ones we're looking at for fluid responsiveness. JEDI is for preload itself. Okay. Afterload, SVRI, and then our contractility are these, and then our pulmonary edema will be here. And when you assess these, you'll be able to tell, should I give my patient more fluid? Should we give the patient more inotrope? Should we give the patient more pressor? Should we give Lasix to get rid of maybe this extravascular lung water? It directs you, this is what we call in ERAS, the goal-directed therapy. Okay, so I will say though, with everything in the ICU and in medicine in general, it's never a good idea to just take one factor. You need to look at the patient in its entirety, but it doesn't mean that you shouldn't look. These things help you when you put your detective hat on. I used to be called Sherlock Gomes when I was on the floor. And while it was, I don't know if it was irritating or cute, but I always think of that. When you put your Sherlock Gomes or Holmes hat on, you need to be a detective in the ICU. And if you see something abnormal here, check out the patient, assess the patient, look, say it's telling you your afterload is high, all right? Check your lactates on your gas, because that's going to be the thing that tells you you've got a problem with afterload. Check the patient out, look at the peripheries. And if you see all of these things are agreeing, and then you make your clinical decision. Same as with CVPs. We say CVPs, there's a big debate about whether they're valuable or not. Well, you need them if you're going to do cardiac output monitoring to get the derived values. You need to actually enter that information in. But without the cardiac output monitor, yes, a CVP is valuable, but walking in and see, oh, the CVP is, say, 8. Okay, let's give the patient fluid. That's not the way to make clinical decisions using the CVP. You need to look at what has the CVP been doing for the last 6 hours. And if you look at the observations and you see, okay, the patient had a good blood pressure and was quite stable at, say, 12. And then it went for the last 6 hours. So it went 12, 12, 11, 10, 9, 8. Then you can see a trend and you can see the CVP is decreasing. And now together with the lower blood pressure, it could be the preload that's low. Have a look at some other things. Check the patient's mucous membranes. Check, has the patient become tachycardic because of this? Check the SG of the urine and check the intake and outputs. And then you'll see, oh, yes, my patient's actually getting behind with fluid. And then you can make a decision about preload, for example. Never do something on its own. Try and put some more factors all together to back up your decision. Okay. All right. Enough preaching. We got this patient referred to us to our practice for query ECMO. It was a young male patient, 27 years old, and the history was near drowning. And let me also tell you that this guy has a history of being in the military, and he was part of like a rescue team. He was a very fit person. He was a trained physical therapist as well, I believe. So why am I mentioning this to you? Off the bat, I'll tell you, we did use the cardiac output monitor on him. And I asked the staff, what is this patient's height and weight? And they told me plus minus 1.8 meters, because he's quite a fit looking guy. And I must say, when I looked at him in the bed, I thought, yeah, that's probably right. But bring the measure, eyeballing it is not okay. I measured the patient and he was 165 centimeters. Imagine if we had put that wrong height in, that would have affected all our values, because it would have thought the patient was bigger than he was. Okay, so I just wanted to mention that that could have tripped us up, and it's very important to get an accurate height. Okay, so you can see that his x-ray is quite whited out. I think when we got to him, his FiO2 was very high. I think it was about 70 or 80% on the ventilator. We've got a blood gas that we arrived on. We can see he's very acidotic, and it's a mixed acidosis. We've got a CO2 that's high, as well as metabolic factors that are low. And screaming out on this blood gas is, of course, the lactates. Okay. I just want to quickly see, can I ask you guys, I know it's just a few of us here, to maybe just unmute so that we can have a discussion on this and not just have me talking about it. Okay. Okay, so we can see obviously our lactates, we're in big trouble with lactate. We wanted less than 2, it's 12.9. We know that lactates above 10 are associated with a very bad prognosis. So of course, this was the right decision, I think, for these referring doctors to refer for ECMO or to ask for help, because this, we are running into trouble. The patients, in terms of timeline, as far as I remember, the patient experienced a near drowning. It was the day before, but it was less than 24 hours. So say 20 hours. So we're nice and early, very good ECMO referral. What else do you guys see maybe on here? Any comments? What would worry you? I think it's the lactate that's the biggest issue.
Yeah, on the pH 7.2, very acidotic.
Very acidotic. So we've got respiratory acidosis, metabolic acidosis, and lactic acidosis all working together to give us a lovely, horrible pH of 7.2. What's frustrating me a lot, and I'm trying to remind everyone, is that it's very important when we do blood gases to put in the right FiO2 and the right temperature. Temperature affects all our metabolic factors, and our shunting and all that will be very inaccurate with the wrong FiO2. I know this patient was, I think, on 70 FiO2, and this blood gas was done on 21 and 37. So it might not be perfectly accurate, but I'm sure the pH will probably still be the same, at least. Yeah. Okay, so we got problems. All right. Let's carry on. What happened next? I just want to see on the ventilation side, we've got a very large tidal volume. Like I said, this patient was only 165 centimeters tall. So this tidal volume is way over what is recommended, right? It's the expiratory volume, but we've got an 855 coming out the patient, and he's 165. So if we're doing tidal volumes of around, what would we say, 6 to 8 mils, say 7 mils, and we're taking our ideal body weight. So we're going to go 65 times 7. We should be 595 on the mils. Let me just maybe explain that in case someone doesn't know. So what we normally do to get a tidal volume that's generally lung protective is we say, or not lung protective, just a normal tidal volume, we say 6 to 8. Am I right, Kath? Is that what you guys do as well?
Yeah, 6 to 8.
So it's easy just to go in the middle, 7. So 7 moles per kilo. And how do we get the ideal body weight of this patient? He's 165. So in males, you take away 100. In females, you take away 110. So you take away 100 from 165, his ideal body weight 65. So 65 times 7 mils, and that should give you your tidal volume that we're aiming for. So his tidal volume is way too high, but it's difficult to do this now because we know this is thrashing his lungs, but we've got respiratory acidosis as well. So it's quite nerve-wracking to do, but we need to protect his lungs. We don't need barotrauma or ARDS on top of all of this. Okay. So also when we got him, these were some of the things that we found. So it was very tachycardic. He was actually hypertensive. His saturation was okay. I must say he was very unstable. We had higher blood pressures and then sometimes lower, but in this moment, he did have a high blood pressure. He was on vasopressin of 5 mils, adrenaline 35 mils per hour, and Dobutrix 25 mils per hour. He was sedated with dormicum and morphine, 3 of each. And I think he was on a Nexium infusion, and he was getting maintenance and some Sodabic as well. Does anyone have any comments about this part?
Those doses of adrenaline and Dobutrix are massive.
They are massive, very high. But I must say, without the proper programming of the pumps, it's very hard to tell what exactly the dose is. We know these are high volumes, but we're not sure exactly what the dosages are. And it's very frustrating when you're trying to make clinical decisions because all the algorithms and indications for everything are all based on dose. And if there's anyone that's watching this that's only been exposed to moles per hour, I'm sure it's very difficult. It's like telling you that the sky is now pink where it's always been blue. It must be very difficult to change. But if you program your pump, the pumps do come up with the dosage. So say, for example, it'll say 0.7 microgram per kilogram per minute, and then it will give you the 35 mils per hour underneath it. So you're not out of your comfort zone. You will still be able to see the mils, and we still need to know that for intake and output. But to make decisions and to wean properly and to know what our patients are on, we really should have the dose. Okay, but we know just from a general feel that these are high doses of inotropes. Okay. What was very concerning to us is Dobutrix, and we'll talk about inotropes. I think it's in June. The theme is inotropes, and I think that's going to be a very empowering talk. But Dobutrix at very high doses actually vasodilates you. And then we're giving high doses of vasopressin, which vasoconstricts you. So having the two on are a little bit conflicting, okay, in this case. So our first main goal was to get this Dobutrix right down. We had enough blood pressure for it. You can see the swing on the A line as well that we talked about. Can you see the peaks are high here and then they go down, 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 and then they go up, up, up. Okay, so we've got a swing on the A line. The patient is ventilated, which is also something to note. But if the swing is happening with the respirations, it's different to the swing happening more gradually like it is here. Okay, so it's immediately what we were thinking is this patient dry because of the swing? The tachy could be from this huge Dobutrix and adrenaline. Remember, they're both going to whip your chronotrope, right? It's going to give you a fast heart rate. So it could be from that. Is the patient dry? Once again, we didn't have a CVP at this stage. He had a at least he had access in the femoral vein, which I'm sure was it was just an emergency sort of measure. So we asked the physician to come put a CVP in for us, a proper one, because we knew we wanted to start the cardiac output monitor just to see if we could get these inotropes down. Okay, so he did come and put a CVP in for us, nice and quick. And we changed his arterial line to a pico arterial line, and we did start that monitoring. I just wanted to see, we also changed some things on his ventilation. We manipulated his APRV, and we had weaned quite a lot of the inotropes, and we then repeated his blood gas very soon after that. And whilst we had slightly better pH, our lactate was still going up, and that was worrying us a lot, because it immediately tells us with the PaO2 that's so high, this is probably all about afterload, okay, or not enough cardiac output. Let me rather say that. Cardiac output that is too low, because it's not hypoxia driven, it's going to be the delivery of that oxygen to the cells. So we needed to figure out quickly what is going on with the cardiac output, and made us even more urgent to put the cardiac output monitor on. Also, I just quickly checked what the resistance and compliance was on the ventilator, and that was normal. So we weren't too worried about that. Okay, so then I sent this report. We quickly made a sort of shock team. We've kind of been operating through WhatsApp groups, which obviously has pros and cons, but I think more pros, because we had everyone put onto a WhatsApp group very quickly. Our team, myself, the people from Surgical Innovations that helped us with the cardiac output monitor, the referring physicians, and of course the nurses looking after this patient, so we could quickly communicate all together. I think when you got such a sick patient and you've got multiple doctors working, I know that myself as an RN, very frustrating when one doctor comes around, oh no, get the Wtrex off. Okay, so you work on that, and then the next doctor comes, no, rather the NOAD off. And this helps for everyone to talk, and we discuss the changes we make and why we're doing it, and everyone's on the same page. And I think it just it makes it so much easier for the patient, to manage the patients. Okay, so I just put some of the communication we had in the groups that directed us. So I said we've manipulated the inotropes a lot. I programmed all the inotropes so that we could get doses. We had even more than halved the Wtrex within an hour. We halved the vasopressin. The adrenaline we weaned a bit more slowly, and we were waiting for the cardiac outputs to arrive. One of our doctors managed to do a TEE, and we could see in the TEE that the heart was underfilled. There wasn't a lot of preload going on there. So the end diastolic volume was low. So that, before the cardiac output monitor arrived, gave us an indication that this patient was very dry. Okay, so we also got communication from one of our other doctors, needs more fluid, not more constricting, all right? Asking about the NOAD, and then you'll see this was actually a comment. We saw the SVRI was going up, and it was all about the SVV was also high, so many factors, and basically that we needed to give fluid. Okay, so we got that on. Here's our pico thermodilution. And if you have a look here, let me rather ask you guys, I don't know if you can remember from the cardiac output workshop, and I can give you that other slide of the normal factors, but I'll quickly just tell you the normal JEDI, oh, they are here. When you go to the screen, here's the normals here, okay, on the side here. So what do you guys think? This is what I found. So everything's pointing, give fluid, get the inotropes off. But now we do a thermodilution, and this is the information we get. What do you guys see? Can you see?
So the extra lung water index is really high.
It's very
so then
high.
you kind of think they're like, don't want to give more fluid because the lung.
Yes, very nerve-wracking.
But-
We don't want to give more,
Yeah.
we don't want the patient to get more pulmonary edema. Hey, and
but
let's have a look
PVPI
why I'm
is
saying that. So our normal extravascular lung water index is 3 to 7. We've got it here at 16. Okay, PVPI, we said if it's less, what we were taught is if it's less than 3, it's a cardiac problem. If it's higher than 3, it's a respiratory problem, a lung problem. So it's high. So we've got a lung problem. Okay, so it's not our heart that's failing, that's causing a backlog of and then generating pulmonary edema. It's from the lungs that we've got a problem. So now it's very unnerving. Should we give fluid? What shall we do? Okay, that's a problem. Then we've got here on the opposite side our JJ. That should normally be between 700 and 800. It's systolic index is all about the preload, okay? And it's half. So we've got half the preload we should have, together with that echo that said the ventricle wasn't filling well. We've got this swinging A line, okay? If we want to get more specific than swinging A line, okay, the SVV and PPV is not showing here, but they were elevated, okay? That's telling us, give fluid. Okay. So we've got this conflicting sort of picture going on here, and it's nerve-wracking because our cardiac index is low. Remember, in younger patients, we should have actually on the higher side cardiac index. Their cardiac indexes are higher than a normal adult. Younger, fit male should have a highish cardiac index, and this is below 3, and this is what is causing the lactate to increase. There's not enough delivery of oxygen to the cells. So this is an emergency, right? This is now going badly. If we leave it like this and we don't change stuff, we're going to have multi-organ failure, okay, in a young person. And by the way, we're trying to dodge the ECMO. We don't want to put the patient on BA ECMO. We're trying to dodge it. Okay.
So you see the SVRI is actually normal. So we don't have to constrict the patient more.
Okay, but by this time, I don't know if you can see here, it took quite a while to get this all sorted. We are when we started, it was quite a few hours before, and by this time, we had just weaned a lot.
Yeah.
So we already halved quite a lot. So I feel like in this moment, if this was my patient, I wouldn't worry too much about touching the pressors. We are in a good spot right now. Yeah, so maybe just walk a little bit and just see what else we can do. I agree, but by this stage, I think we already had the Dobutrix off, and our vasopressin, I think, was on like a very low dose, and we were working on weaning our others. But I agree, maybe just stop a little bit. But I think it's definitely sure that our problem is preload, and what gave us confidence to give the fluid is the history. So near drowning, okay. Also, there was a big debate whether this was fresh water or salt water, and it was salt water. And with that history, having pulmonary edema was part of that. It was part of the drowning. Who knows what it was the day before? It already could be, we don't have a trend. It already could be coming down, okay? And the patient is ventilated already, which it already, gave me confidence. So I felt like, let's just give fluid because it seems like that is the issue. And then we watch the trend. The patient's already ventilated. We're in trouble. We have to do something. So we started with fluid resus, basically. And we did that. And after 1 hour, check what happened with the extravascular lung water. Let me just go maybe back here. We were on 16 and 5.1, and we came down to 13 and 3.7 with fluid. The only thing that was added was fluid. Okay, you can see the heart rates also come down, also probably from weaning those drugs, but maybe also because of this fluid. Our JDI Let's have a look at that. Went up very little, from a low 400 to 499. Okay, so, but this is only 1 hour, all right? So the next, we kept on giving fluid based on this JEDI and our PPV SVV. And the next day, you can see the extravascular lung water is nicely now, look, it needs to be probably under 7, but it's under 10. It's come down quite a lot, and it's actually switched now. The PVPI is actually in the normal range now. Remember, it's only telling us is a cardiac issue if the extravascular lung water is abnormal. Okay, so we're quite satisfied with that. Our JEDI had come up quite a lot, but still low. Okay, we've got a normal SVV at least, and a big relief. The cardiac index has come right. Do you see there, 5.4? Obviously, our gases had improved tremendously, and we could wean all the inotropes off very soon. This patient was extubated in a few days and is completely fine and normal. And I really feel like the cardiac output monitor helped us so much to treat this patient. We dodged ECMO and we got him off of all these big guns. Very difficult with just the monitor in front of you to manage this patient and watch that lactates increasing, and, you know, not being sure where to go. So I don't know if you guys have any thoughts about this case. Obviously, it's very different. It's not the normal that we'll get. Usually, in my world, at least in the cardiac side, we don't have a near drowning with pulmonary edema confusing everything. But I just wanted to show you, like, just to try and think about it, how to go about thinking about the abnormalities that you might find. Yeah. Do you guys have any questions? Did you think it was cool? I thought it was tremendously cool. Was, hey. I hope that from this little session today that you might get a bit more perspective of how I'm putting it together and how to make those clinical decisions, and maybe when to put it on, if anything else. And then, of course, not to use just one factor in absolutes. It's having to put it all together, and how incredible teamwork is. Very difficult to manage this as a lone ranger. But if you've got a cool team and you can bounce these ideas off each other, you can, you know, get some more confidence to give the fluid despite the extravascular lung water being high. Yeah. Yeah, so if there aren't any questions, I think I need to run now. We're doing an ECG workshop at MediClinic, so we need to get chats. Let me just see, is there a chat? Is there something? Oh, thank you. Yes, pleasure, Anisha. Cool. I'll see you guys next time. Bye.
Bye.